We will now open Dr. Mufti's presentation to questions that will be fielded by Dr. Pizzola.
So the first question is by Dr. Yagunidis, Germany. Would you apply remission induction pre-transplant also to patients with 5 to 10% blast?
Yeah, the straightforward answer is yes. I think for too long, we kind of have focused too much on 5% blast versus 10% blast, got going with intensive chemotherapy, intensive conditioning in people who have between 5 and 10% blast, rather than reducing the blast cell percentage in the first instance. One of the main reasons for that has been this nervousness about how patients are going to tolerate intensive chemotherapy and whether some of the patients become transplant ineligible because of the consequences of intensive chemotherapy. That's kind of number one. Number two is that I think as time has gone on, our confidence on reduced intensity conditionings has also increased. As I showed, for example, say with triosulfan containing regimes, that it is quite clear that the regime is tolerated extremely well. And also the data published thus far would suggest that the relapse rate post-conditioning is relatively low. So I think for those reasons, as well as the general acceptance, if you like, that we would, when we transplant an AML patient, we want the patient to be in complete remission. And it should be no difference to in MDS, because in MDS as well, we should also transplant if the blast cell percentage is less than 5%. So my own feeling has been, yes, they should receive whatever treatment to bulk reduce them to get them to less than 5% blast stroke CR.
But Ghulam, you mentioned molecular genetics. So what about reasoning in terms of molecular genetics rather or in terms of blast? Would you move to transplantation, proceed to transplantation, provided that there is a reasonable molecular remission?
I don't know about molecular. I mean, I think molecular has been absolutely fantastic in terms of exploiting the technology that is available. And as we go on, the more and more of the technology is available, as I showed and as we are doing now, that it is really possible to identify very small numbers of residual cells. Whether that actually matters, I don't know. To what extent it matters, I don't know. But from first principles, you would think that lower the tumor burden, whether that is immunophenotypically characterized as Uwe Platzmacher showed in his Azelius trial of doing 5-azacitidine, or whether that is molecularly done. I don't know, because I think thus far, it's also a question of how far do you take the molecular? Do you take the molecular to mean that you need to have less than 1% clone, less than 0.1% clone? But there hasn't been enough data on significant numbers of patients to try and confidently resolve that issue.
Okay. Guillermo Sanz, Valencia, sent 2 messages. The first one is just excellent presentation, Ghulam. The second one is a comment. Transplantation should be considered as the best initial approach. But at present, we are transplanting only 10 to 15% of patients.
Yeah.
In your clinical practice, Ghulam, do you consider allogeneic transplantation as the optimal initial approach, provided that the patient has a donor and so on?
Yes, and I think we do. That's because we have been proponents of transplantation for MDS for a very long time. But I think generally what Guillermo is saying is absolutely right, that even the US studies, the Medicare-Medicaid study of over 3,000 patients, that it is true that only 15% of eligible patients with MDS have allogeneic transplants, whereas it ought to be much higher than that. And one of the reasons for that, as I was suggesting, is that we don't really have a perfect handle on what are these comorbidities, what are these frailty indices that might complicate the post-transplant course. And also some of these are dated a bit, because I think they were from the times when we still were doing the high intensity conditionings. So I think this whole area needs to be reinvigorated, because the truth of the matter is we have learned a huge amount about the molecular genetics and other things in MDS, but in terms of prognosis and curability, it's only transplant that actually cures these patients, and that goes without saying. So I think we're not exploiting this treatment to the extent that we should be, in my view.
Okay, Dr. Misk is asking a question about the efficacy of allogeneic transplantation in treatment-related MDS.
Yeah.
You have data?
There have been, I didn't present it here, but I think this has been done very well in several reviews, and EBMT has analyzed this as well. I think the problem with TMDS patients has been this issue of TP53. I think before we knew that there might be differences in the prognosis between multi-hit versus monoallelic P53 mutation, it was all a kind of P53 and monosomal karyotype related outcomes. So those patients who have those bad features, they did poorly. But I think again, that again is changing as well, because higher number of P53 positive mutated patients are now going into remission with venetoclax and 5-azacitidine and similar regimes. And even higher numbers will go into these remissions, whether that's with APR246 or whether that's with anti-CD47 or anti-CD70.
Okay, thank you very much again, Gula.